So we'll try and make some key points here. These are about troponins. Now, we determined yesterday that about half of you have regular troponins, half have high sensitivity. So this is supposed to be how we determine this. So we know that the normal threshold for a troponin is 0.01 nanogram per mil. That's the test we say. That determines if you're above that, it's positive. If you're below that, it's negative. And that's because that's determined to be the 99th percentile of levels in the general population. So that's why it was chosen as a threshold. All a high sensitivity troponin does is it's 100 times more sensitive. So instead of being 0.01, it's 0.03. So it's 10 times more sensitive. 0.03 is its cutoff. Whereas regular troponins is 0.01. And that's why the detectable range is 0.003. The threshold is 0.014, which is the same as a regular troponin of 0.01. So 10 times more sensitive. The question is, what does that help us with? Well, overriding what this means is you can forget the term unstable angina. If you use high sensitivity troponins and you meet the two criteria for a negative high sensitivity troponin, which is it's either below 3 nanograms per liter or 0.003, so it's below that, or it doesn't rise a certain amount in the two tests you do, they don't have coronary artery disease that causes risk. So you know some of those patients that you admit to the hospital because you're kind of concerned by the story. I've been having chest pain. 3 days ago, I'd get chest pain halfway up the stairs. Yesterday, I got chest pain going up 2 stairs. Today, I get chest pain thinking about going up the stairs. And you're going, boy, that patient's got to be admitted. And I don't care if their troponins are negative. They got to be admitted. Well, it's now been determined if your high sensitivity troponins are negative, they have 0 MACE risk over the next 30 days. So that means there is no unstable angina. They have ACS that requires something to be done, or they don't. And there's no category where you're not really sure. There is a category we're going to talk about called observe, because the point of high sensitivity troponins is you rule it out, you rule it in, and there's a period for the emergency physician that's called observe. So it's not perfect, but it does show you that if your troponins rule out, you don't have, no matter what your history is, anything to worry about. Okay? What's really neat, if you have high sensitivity troponins, is you can do that in an hour. You can do one test and an hour later do a second test. So it's a very short turnaround, and it gives you some very definitive information. Because the test is not precise, it's not always the exact same number. It's why the criteria of a delta is important. So that you have to, if you get a certain change, usually 4 to 7 nanograms per liter in an hour, that's considered positive, even if it hasn't exceeded the threshold of 13. So if you start at 5 and you go up to 12, it's positive, even though you haven't passed the threshold of 13. Okay? So that's why, because of a lack of precision. So there is a delta that you consider. The other thing you have to consider about high sensitivity troponins is that it's the delta, and it doesn't matter whether it's going up or going down. Because high sensitivity troponins peak early, and they go down. By 6 hours, they're already going down. So if you see someone's been at 6 hours, and your initial one is 12, and now it's 3 1 hour later, that's a positive delta. So it's not like the old days where it only was important if it went up. Going down can be just as bad. Okay? Can some patients be ruled out with a single high sensitivity troponin? Wouldn't that be great? Tastes great, less filling. We do one test, you go home. So the answer is number 2. Diagnostic accuracy of this. Low risk by history, normal ECG. So we talked about the heart score, low risk by history, normal ECG, and an undetectable first troponin. So that's below 3 nanograms per liter, they go home. Allowed 29% of patients to go home with no risk. I repeat, normal ECG, low-risk patient, troponin below 3 nanograms per liter in a high-sensitivity troponin, they could go home. If you use the threshold of 14, which is the current threshold for regular troponins, instead of the undetectable rate of 3 or 4 with the high sensitivities, there was an 8% miss rate of MACE with a single sample. So this is very clear. You cannot use regular troponins and a single test. The problem is, of course, is very few people have an undetectable high sensitivity troponin. That's the problem. Number 3, an industry-funded study found essentially the same result. Number 4, the use of very low concentrations of high sensitivity troponin to rule out MI using a simple blood test. This is a study that had a 16.6% MI rate. Now, some of your hospitals, you say, well, we don't see that many MIs and all the chest pain patients we have to see. With high sensitivity troponin, since all of your ACSs, all of your unstable anginas are now MIs, you're going to find your MI rates are going to be above 10%. So this isn't an unrealistic figure of 16%. 2 out of 471 diagnosed with MI if undetectable level on one test and ECG without ischemic changes, without using any clinical risk stratification. Because remember, if you don't have a troponin that's positive, you don't have coronary disease. There's no such thing as unstable angina. So they said their miss rate was less than 0.5%. We talked about this yesterday. You have to have a threshold somewhere where you're okay with missing something. I would submit that a threshold that's less than 0.5%, most people would say is an acceptable miss rate. Because you can't pick up everybody. So this study, number 4, says you don't even, with high sensitivity troponins, you don't even need a clinical risk stratification tool. To the ECG, to the troponin. If the troponin is negative, they go home. Number 5, can we do a point of care test? Now, wouldn't that be great? The patient walks in, they do an ECG, you prick their finger, you do the test, and 6 minutes later, you can go home, sir. No fuss, no muss, you're out the door. How many of you would like that? Right? So, it's not yet FDA approved, but this test was done in New Zealand, attained the same parameters with a point of care test as the blood test itself. The undetectable threshold of 3 nanograms per liter identified 43% of patients at low risk with a sensitivity for MACE of 100%. So number 5 is the future. The point of care bedside test that in 3 minutes tells you that you can send, that's right, 43% of your patients home without any further testing. That is a change in the way we practice. So you may not like high sensitivity troponins because of their lack of specificity, but if in 10 minutes after seeing the patient, I'm sending them home because of their ECG and their high sensitivity troponin, that sounds pretty tantalizing. What? Doesn't matter. It doesn't matter if they still have chest pain.
Well, since it's a delta troponin, if the patient comes in and says, I had chest pain for 6 hours.
Right, but this test says if it's...
He comes in 6 hours after that where the delta troponin can drop off and it's negative.
But it doesn't drop off to below 3.
How long does it stay up?
It stays up for the usual dose of troponin.
7 days.
Yeah. So this is, you're still going to have to deal with all the crap of the lack of specificity. Okay? Because it's going to be falsely positive on a whack of patients. Up to 30% of your patients will have false positives. But there is a clear subset of patients, somewhere between 30 and 40% of your patients, with high sensitivity troponins. If there's not a detectable troponin, so it's less than 3, they go home. Period. You're done. That's what 3 studies in a row here say. I know. So Oh, we got a long ways to go, but what did we talk about at Editor's Choice, right? Here are the rules for how you work up a PE, and 35% of people don't do it. I mean, the fact that we don't follow what the literature says we should do, it just seems to be our nature, unfortunately. And what you're describing is sadly true everywhere. My hospital, your hospital. I don't know how to get over that. If I did, I'd be running a department and be a really happy guy. I ran 3 departments and got frustrated on a regular basis.
What was the time of onset for the chest pain?
Anyone who came through the door. We'll get to that in a little bit more, okay? So at some point we have to ask how many patients are being tested that have no risk of cardiac disease, and why are we testing them? There are several rule-out protocols. Which are the best performers and how should I use them is one of the questions for this chapter. There's rule out, rule in, observe, remember? Number 6, validation of presentation and 3-hour high sensitivity troponin to rule in, rule out. This is a pooled analysis of 5 studies, less than 12 hours of pain, nil acute on the ECG. They did an HST at arrival in 3 hours. So they didn't just look at the people with an undetectable level. They took all comers, okay? 13% MI rate using no clinical risk scoring tool. Sensitivities vary from 93 to 95%, suggesting rule in worked well, but not rule out, which is contrary to the previous studies. 2017, number 7, 16% MI rate, no clinical risk stratification was done, 0 and 1 hour levels. Their criteria was below 5 nanograms per liter at presentation, with an absolute change at 1 hour of less than 2. That's a pretty tight delta, less than 2. If it was undetectable at time 0, so less than 3 or less, or if 0 and 1 hour protocol met the delta, then the sensitivities were better than 99%, and therefore these people are safe. So again, undetectable, no delta in an hour. So though we haven't gotten to one test, a 1 hour delta seems certainly to be one of the things you can do, and probably get your hospitals to agree on. Number 8, Clinician's Guide to Early Rule-Out Strategies with High Sensitivity Troponins. This is a commentary. They suggest that a very low high sensitivity troponin level in the first sample might reasonably exclude AMI in up to 40 to 50% of patients who are otherwise at low risk and present more than 2 hours after symptom onset. So if you have someone who's there and it's been 30 minutes, they're not yet sure what that means. That's not the average of the people we see, though. The average we see in North America is about 4 hours time to presentation. Certainly 2 hours is a very frequent number that's exceeded. And so the commentary supports the above argument that if you have a low-risk patient, as per Hart, and a first troponin that's negative, undetectable, they go home. If you take all patients, so you don't use a clinical risk stratification tool, and you do a 1 hour test, and you look at the delta, you can send a whole bunch of people home. So there's a way to do it with low risk criteria. There's a way with a 0 and 1 hour to do it with no risk stratification. So that means that the frightening history doesn't exist anymore, because there's no consequence. They're positive high sensitivity troponins, or they're not. And if they're not, their MACE risk at 30 days is 0. You're all skeptical. You're thinking, I remember that patient I saw this weekend. There's no effing way I'm sending that patient home. You're all thinking that right now. Now, people who have raised their hands yesterday and said they had high sensitivity troponins, do you agree that there's no such thing as unstable angina anymore? Or are you still admitting people with scary stories, even though you have all the proof in the world that there's no risk for them? The ones with scary stories come from cardiology office, and they get admitted, even though the troponins are negative.
They're the ones I send to the cardiologist.
Yeah, the ones that send them there to be admitted to the ER.
Really? For what reason?
They're having a troponin leak.
Yes. Because if you look at the people who previously had regular troponins negative and who had risk of MACE, they all have a troponin above that threshold of 3 or 4. And it's between 3 or 4 and the detectable regular troponin of 14. They're in that range. And when you take that group away, the ones who are left don't have risk of MACE.
They don't have risk of MACE, that doesn't mean they don't have disease.
But if they don't have risk of MACE, then what are we doing to them? Why are we trying to do something to them when if it's not broken, why are you trying to fix it?
MACE is a 30-day.
Yeah, but some of these studies actually look them out to a year and say there's no consequence. So, I mean, at some point, you know, futility raises its head.
I'm not arguing with you.
I know. And again, this all comes back to what I talked about yesterday, which I think is so important in this discussion. What is your threshold of risk that you're comfortable with? Okay? People have ingrained patterns of practice, and so this whole concept of high-sensitive troponins and truly eliminating risk, and there's no such thing as a scary story anymore, is going to take years to wear that away and get people to say, okay, I don't care what you told me. The tests tell me you're not at risk. I'm sending you home. That is so against the natural thought process of many of us that, yeah, but he told me this, and he was sweating, and he was this. I can't send this guy. That's eating at you. It just is. I understand that. Renal function and scaled troponins. I love this. So, this was a study number 10. The overall incidence of MI was 19%. There was at least one single scaled troponin value greater than 10 nanograms, that 0.01, in 45.9% of patients with renal dysfunction. 50% of people with renal dysfunction had an elevated troponin, versus 23% of those who didn't have renal dysfunction. But the MI rate was 19%. So that meant in the kidney group, 25% of these patients had an elevated troponin for whatever reason. The problem with this, and we're going to get even into more detail with the next study, is that having an elevated troponin when you have renal disease, your risk of 1-year mortality is 3 times higher than if you don't have an elevated troponin. But you don't die from coronary artery disease. You die from some other cardiac problem. So it's not like you don't have coronary artery disease, your troponins didn't go up, you're fine. It's your will and testament should probably be in order. I don't know when you're going to die, but your chances in the next year aren't so good.
Their risk of coronary artery disease is higher, period.
Yeah, but they're not dying from coronary artery disease. And we'll get into this. This is even more true in 11. If you look at 11, this is really remarkable. Looking at all patients who do not have ACS, proven to not have ACS, would have an elevated troponin. These were high-sensitivity troponin levels were less than 5 nanograms, so undetectable, in 62%. Then they went from 5 to 9 and 21%, 10 to 14 and 8.6, 15 to 29 and 5.7, 30 to 49, that's pretty high, 0.03 to 0.04 in 1.5%, and greater than 0.05 in 7%. So we're talking about a pretty high troponin here. The rate of 1 to 3 year mortality, MI, and heart failure all increased with each level of troponin elevation. So the cardiovascular mortality odds ratio went from 3.59 all the way up to 27 odds ratio if your troponin was above 0.05, but it wasn't related to a coronary artery disease problem in the emergency room. So you did the first test with a regular troponin, it was 0.05. You went, oh shit, that's high. But you repeat it 4 hours later and it hasn't moved. And you look at the chart, and a month ago we had a troponin of 0.05. This is just his troponin. 27-fold increased risk of MI, death, or CHF in the next 3 years, even though he doesn't have coronary disease in front of him. But the problem is, there's nothing we can do about it. Admitting them doesn't help them. It gives them more stress, it costs a lot of money, and it changes nothing in the outcomes.
Well, but you'll have
maybe in your place, in my place, if I show 2 successive troponins that are elevated but normal, not a single doctor in my hospital will admit them. They will all refuse. So let's get down to the really important question, which of course nobody seems to care about. Has use of high-sensitivity troponins improved outcomes? Well, we're picking up all these people. We know they're at risk for MACE much better than we did before. We now even know there's no such thing as unstable angina because really they've actually had a rise in their high-sensitivity troponin. We now know who's at risk. What does that mean? It doesn't mean a damn thing. So if we take a look, hang on, the first study, number 13, HST had higher predictive association with mortality than normal troponins, higher rate diagnosis of ACS, no change in outcomes, despite a 6-fold increase in performance of bypass grafts, a 4-fold increase in echocardiography, coronary angiography, and stenting. We quadrupled things because of the results of the HST. We did 6 times more cardiac surgery, and there wasn't a single change in outcome for the patients. So it's a surrogate marker about which we can do nothing. It drives the economy really well, but does dick for the patient. So you have to ask yourself, then why are we doing the test? It doesn't change anything, except it gives the patients a whole lot more procedures and doesn't change the rate at which they die. You think, well, that must be a one-off study, but no. Number 14, troponin versus high-sensitivity troponin, look at 1-year mortality, 50,000 patients. Using the high sensitivity, after 6 months, they reclassified 17% of the patients of having an MI that were not declared MIs with the regular troponins. So you would think 17% greater MI, they must have had a lot more deaths. Well, it turns out, not associated with a lower subsequent incidence of myocardial infarction, no change in rate of cardiovascular deaths. The HST had no impact on the outcome or duration of life of the patients. It's sort of like having an electron microscope. I can see everything. I just don't have a clue what I'm supposed to do with the information. The MRI picks up all sorts of stuff. I don't know what to do with it. D-dimer gets us testing way more people, but you know what the death rate is from PE? The same as it was 20 years ago. It hasn't changed a damn thing. All these anticoagulants, all this testing, it hasn't changed mortality rates in 20 years. Do you realize the rate of death from MIs, acute MIs, has not changed since 1992? What did we find? What did we discover in 1992? Streptokinase and aspirin, ISIS-2, aspirin. Since that discovery, despite all the statins, all the medications, the CCUs, everything else, there has not been a single percentage point or decimal point change in mortality from acute MIs. And yet the cost of care has gone rocketing through the ceiling. This is another example. We do a whole lot more. We diagnose more acute coronary syndromes with MIs more. We stick wires in them, we put balloons in them, we bypass them, and not a damn thing changes. So, the benefit of high-sensitivity troponins, you don't have unstable angina anymore, and you get to pick up people who have MIs. It allows you to send a bunch of people home who have no risk of MACE over the next 30 days, 6 months, whatever. It does all those things. Its specificity is terrible. It's 70%, it's 30% false positives. And it doesn't change a damn thing for the patients and who you do the test. At great expense to the system. So how many of you want to embrace high-sensitivity troponins and say, yes, I want them tomorrow in my emergency department? Lots of you. Because again, if you could do a high-sensitivity troponin at a point-of-care bed test and have a normal ECG and a normal high-sensitivity troponin in 10 minutes and you could discharge the patient, it would make your lives simpler. You just have to deal with all the downstream unintended consequences of that getting that, which is a whole lot more diagnosed MIs, a whole lot more interventions and procedures that don't help the patients. We get to decide if that's worth the cost.